Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. NIK NIKAM. I'm a cardiologist from Houston, Texas, and the presentation is for educational purposes only, and I have no financial disclosures. Please do subscribe to our YouTube channel. In this presentation, we are going to look at some M-mode tracings that may be useful in preparation for echo boards. Why M-mode? M-mode echocardiography in this era of 2D, 3D, TEE, cardiac CT, MRA, nuclear stress test. Why do we need an M-mode? This is an obsolete technology. Not so soon. M-mode has better estimation of time intervals. M-mode is quite useful in evaluation of dyssynchrony. When the wall motion begins, when the wall motion terminates, and how does it correlate with the various phases of cardiac cycle. It is also useful in evaluating pressure half times, even in the presence or absence of valve regurgitation. It also gives us an insight into the mechanism of paradoxical pulse, paradoxical wall motions, and of course, constrictive pericarditis and tamponade. It is also useful in diagnosing arrhythmias, for example, atrial flutter, where you may be able to see the flutter waves better than you can discern them on an electrocardiogram, especially when the rate is fast with a 2-to-1 conduction. Color M-mode is excellent for timing and flow propagation in patients with tricuspid regurgitation or mitral regurgitation. And the most important reason why you need to know about the M-mode echocardiography is because it is complementary to the two-dimensional and TEE studies. And the real reason is there are going to be some questions on M-mode on your echo boards. So that's the reason you need to learn about M-mode. But I enjoy M-mode because it gives us a very precise insight as to some of the mechanisms of wall motion abnormalities, and also as far as timing of various events are concerned during a cardiac cycle. So when we are looking at an M-mode, whether we are looking during a routine examination or when you're sitting and sweating in the echo board examination, the most important points that you want to keep in mind are that what structures are you seeing? What part of the heart is displayed on that particular image? What is the paper speed? What is the heart rate? What do the normal structures look like? What abnormality do you see? What are they pointing that arrow towards? What are they trying to get at it? Are we in a systolic phase, diastolic phase? Are we looking at a valve, a muscle, pericardium, pleura, vascular? There is always an EKG on the tracing. Pay attention to the EKG. There may be a clue to your answer in the electrocardiogram, especially if these patients have bundle branch blocks, pacemaker rhythms, premature atrial beats, and any other type of cardiac arrhythmias. So there's a whole lot of information that we can gather from an M-mode echocardiogram and extrapolate it to a two-dimensional echocardiogram long before you record a two-dimensional echocardiogram to confirm your points. Okay, here is a composite picture of an echocardiogram study. First, I would like you to just pause, take a piece of paper and pencil, and write down all the things that you recognize in this particular image. This whole presentation is going to be sort of interactive because this is a setup in a question-answer style. So I'm going to be pausing after each new image. You will have time to write down your findings. I'm not going to give you multiple choice questions because I want you to independently think and identify what the normal or abnormal finding that you see in these tracings. Then we're going to come up with a discussion and add some more background information so that we have a more solid understanding of M-mode echocardiography in the context of 2D and 2D, 3D and TEE studies. Okay, enough said about the introduction. So let's begin with what we are seeing here. Here is an M-mode probe going at various levels of the cardiac structure. This one represents the probe going through the mitral leaflets, and here we see the interventricular septum, and here we see the opening of the mitral valve represented by D, E, F, A, B, C. And then we have a mirror image of the posterior leaflet. And in the background we see the movement of the posterior wall, and here is the epicardium. And beyond the septum in the front we have the right ventricular cavity, and we are not seeing the right ventricular wall, but in many cases we should be able to see the right ventricular wall if it is visible on the 2D echocardiogram here. So that is a beginning. Now we can use this one and move the probe a little bit further down, just at the level of the papillary muscle, where we can measure left ventricular dimensions and arrive at the left ventricular size, left ventricular function, and also any evidence for left ventricular enlargement. Here we can look at the thickness of the interventricular septum, the end diastolic and end systolic diameters, the thickness of the posterior wall, the thickness of the pericardium, any evidence of a pericardial effusion either in the posterior region or in the front, a whole host of things that can be evaluated in these. And here this is at the aortic leaflet or the aortic cusp level, and you can see the closure and opening of the aortic cusp, which corresponds with the electrocardiographic cycle. Then we have the left atrium here. So there's a lot of information that we can gather about the heart, and that's what we did for several decades before the 2D and 3D came into existence. We relied predominantly on M-mode echocardiography and made excellent diagnoses which were confirmed by pathological or surgical studies. Now here is an M-mode picture. I just want you to take a moment, pause the video, write down what you see, then we will make a progression further. What I would like to point out in this particular M mode is that, of course, like the previous one, we saw an M mode going through the mitral valve leaflet level. That's very important to understand at what level these recordings are done. That tells a lot about what we are looking at and how to use that information in coming up with a diagnosis. So this is at the mitral level, and we see the diamond-shaped opening of the mitral leaflets, both the anterior and the posterior leaflets, and here are certain designations given to the mitral valve opening. There are 3 phases to a mitral valve opening and flow across the mitral valve during the diastole. During the early diastole, we have the A dip, which represents the early opening of the mitral valve. Then there is a stasis, and followed by an atrial kick, after which the systolic phase begins when the mitral valve is closed. So here we have a point at which it opens is known as the D. Then we have a D to E. Then we have a E to F slope, which is an important index of mitral valve function. Then we also have a wave, which is also representing the atrial kick, and it also has a significant importance in patients with hypertrophic cardiomyopathy or in patients with cardiac arrhythmias, especially involving the upper chambers. So that is an overview of a mitral valve M-mode echocardiogram. Let us proceed further. And this is just another example showing you a live tracing with the D, E, F, A, C. What happened to B? B represents the downslope of the atrial contraction. Actually, the point A represents the maximum deflection, whereas the point C represents the point of cooptation of both the anterior and the posterior mitral leaflets, and B represents the slope of this deceleration. Take a look at this tracing. Instead of seeing one A wave, we see multiple A waves. When we see something like this, we would be concerned about cardiac arrhythmia. Whenever you are concerned about an irregular pattern on the M-mode echocardiogram, try to look for other clues. And one of the other clue in this particular tracing is the electrocardiogram. And if you look at the electrocardiogram, and here we see atrial flutter waves, and that helps us to identify atrial flutter. Similarly, in case of an atrial flutter with 2-to-1 conduction, where it may mimic sinus tachycardia, AV-NRT, or junctional tachycardia, an M-mode echocardiogram might help you to identify flutter waves, which may help to make a differential diagnosis. So it's important when we are looking at a tracing, pay attention to every point on the tracing, and then you will be able to make a much more meaningful diagnosis. All right, take a moment here, see what you're observing, write down everything that you see that relates to this image, then we will proceed. There are a lot of important points in this particular image. That's why I am posting this one. Okay, let's proceed. This is an image at the aortic valve level. Let me go back here. This is an image at the aortic valve level. This is the aortic left ventricular systolic phase. Here is the opening of the aortic leaflets, which forms like a box, and then this is the diastolic phase of the aortic valve, where it is completely closed. And look at the movement of the aortic root. The aortic root movements may be subdued in patients with low cardiac output. So that itself gives you an idea as to the status of the left ventricular function. Number 2, we also look at the left atrium, which is right behind the aorta. The left atrium is measured from the highest point of deflection to the flat line that we generally see here, and that is the left atrial dimension that was used for years and years before we got two-dimensional echocardiography. The other point I want to bring out to your attention is the aortic valve opens briskly, it stays open during systole, and it abruptly closes. There are many situations where we are going to see variations of the aortic leaflet opening and closure along with the changes in systolic phase that will help us to identify. Here you see the aortic closure is in the midline. That means this is an example of a patient with a tricuspid aortic valve. However, in patients with bicuspid aortic valve, we may see this eccentric closure of the aortic valve. Of course, that is not exactly right in a modern day when we can get a 2-dimensional or 3-dimensional echo, which can give us a much better idea as to whether we are dealing with tricuspid or quadricuspid or a bicuspid aortic valve. All right, let's continue. Okay, here are some other examples of aortic valve disease that we may come across. We talked about the normal aortic valve, and in this tracing there is increased what is called shaggy dense echoes. We don't even know where the aortic valve closure line is. It may be this one. If this is the line, then we are looking at an eccentric aortic valve closure, which may suggest the presence of a bicuspid aortic valve. I'm just saying, I'm assuming it is not clear, but if you look at a 2D echo here, there's a lot of calcification and a lot of dense echoes coming from this region. Anyway, the aortic valve opening is extremely small, probably less than 1 centimeter. If the aortic valve opening is less than 1 centimeter, that means it has critical aortic stenosis based on M-mode echocardiography. So there are a lot of features pointing towards an aortic stenosis. One, increased echoes during the diastolic phase. There is reduced aortic valve opening, and there is eccentric closure of the aortic valve. So all these findings suggest we are dealing with aortic valve pathology, which may be degenerative in nature, and we need to look for other clues in the left ventricle, and also we need to look for other clues in the left ventricle. Here's an example of a premature closure of the aortic valve. The premature closure of the aortic valve happens when there is reduced flow across the aortic valve during the latter phases of the left ventricular systole. This can happen in patients with reduced cardiac output, like in patients with cardiomyopathy, and this is also supported by the fact that the aortic movement is considerably reduced compared to a normal aortic movement we see here. So all these things are important when we are watching these tracings, especially in M-mode setup. And here's an example of a midsystolic notch. A midsystolic notch which may be seen in patients with like hypertrophic cardiomyopathy. We have a fairly reasonable wall motion, and the left atrium is shown here. Let's move on to the next tracing. Here's an example of a hypertrophic cardiomyopathy. Echocardiograms are extremely useful in identifying patients with hypertrophic cardiomyopathy and also in terms of timing of the various abnormalities associated with the hypertrophic cardiomyopathy. In this patient, we have an abnormally increased thickness of the interventricular septum compared to that of the posterior wall of the left ventricle, and along with that we have reduced septal motion plus anterior motion of the anterior leaflet, which is called the systolic anterior motion or SAM, which almost abets the septal wall during the systole. So we have a reduced E to S slope. There's abnormal septal motion. As you can see, during systole, when the posterior wall is moving inwards, the septum is moving outwards. Usually you expect both the septum and the posterior wall to come together during cardiac systole. So there is an abnormal septal motion, and if you look at the electrocardiogram, there's a wide QRS complex. Whenever you see a wide QRS complex, that means we may be dealing with bundle branch block, especially if we are dealing with the left bundle branch block. There may be abnormal sequence of activation of the left ventricle, which can lead to septal dyskinesis compared to the posterior wall normal motion. So we're going to highlight on that again when we come to a different tracing. But some of the findings in this particular tracing, there are a lot of them, that is increased thickness of the septum, much more than the posterior wall, even though the posterior wall is also extremely thick. So we have an asymmetrical septal hypertrophy or HOCM, along with the SAM, which suggests there is an intracavitary gradient during left ventricular systole. There is reduced E to S slope, abnormal septal motion, and these patients may also have mitral regurgitation due to the systolic anterior motion of the leaflet, but also because of the left bundle branch block, where the cooptation of the leaflets may not be accurate. And in addition, there may be a midsystolic gradient across the outflow tract. What more do you want to know about a patient with hypertrophic cardiomyopathy? We already covered so many points just using M-mode echocardiography. So M-mode echocardiography is not obsolete, it is not history, it is highly complementary to two-dimensional echocardiography. Let's continue. Here's an example. Take a look at this. There are some clues. Write down all your findings. As I said, I don't want to give you a multiple choice questions. I want you to independently think and analyze each structure from the beginning with the EKG and write down everything that you see abnormal. I mean, that is how I teach students, residents and fellows electrocardiography. I give them a copy of a normal electrocardiogram and I say, does this look like a normal electrocardiogram? Yes or no? No? Then what is different from the normal electrocardiogram, and where is the difference, and how is the difference? It's the same principle we should apply when we are looking at a tracing, because it is highly unlikely they're going to give you more than one normal M-mode echocardiogram, because all the rest of them are going to be abnormal. If we know what the normal one looks, then we can quickly pick out what the abnormal ones look like and try to put the pieces of the puzzle together to find out what is the composite abnormality in that particular tracing. Anyway, let's continue here. First of all, there is decreased thickness of the septum. There is increased right ventricular volume. When we say increased right ventricular volume, you have to know what is a normal right ventricular dimension in an M-mode echocardiogram. Here we have 1, 2, 3, 4 centimeters. The normal dimension is something like 3.2 centimeters of the right ventricle. Your septum is practically flat and it is also thin, which may suggest there might have been a previous septal infarct. And if you look at the posterior wall, even the posterior wall motion is considerably reduced. There is an increase in the left ventricular internal dimension. If you measure it 1, 2, 3, 4, 5, 6, 6.5, 6.5 centimeters. What is the normal dimension of the maximum dimension of the left ventricle, which we're going to be talking about in the later phases? It is 57 millimeters. So the left ventricle is moderately dilated, and along with that, the mitral valve E to F slope is quite separated from the septum as compared to some of the previous ones which we saw. The normal septal separation from the E point should be no more than 7 millimeters, but here it is 3 centimeters. Tells us that one, we are dealing with a patient with biventricular enlargement. There is reduced contractility of the left ventricle involving the septum and the posterior wall. There is increased septal separation from the E point, and all of these things point towards congestive cardiomyopathy. And in these patients, we may also see some other evidences like left atrial enlargement or elevated end diastolic pressure. So we got a lot of information from this one particular tracing. Let's continue further. Now here is an example of a patient with septal separation, which is 1.2 centimeters, which is slightly increased. And the point that we want to make here is there is a notch here. A B notch usually suggests elevated left ventricular end diastolic pressure. So the slope should be straightforward, where the line meets directly with the opposing line coming from below. However, if you see a notch, that suggests an increased left ventricular end diastolic pressure, which is not uncommon in patients with congestive cardiomyopathy and congestive heart failure. And here's another example of a patient with a B notch, which we talked about, that represents elevated left ventricular end diastolic pressure. What do you see in this tracing? What structures does this represent? What is your diagnosis? All right, let's come up with something. This is an M-mode tracing of a pulmonic valve. It is similar to the aortic valve, except we are only able to see the posterior leaflet movements, as opposed to an aortic valve where we can see both the anterior and the posterior, or the non-coronary cusp or the coronary cusp, depending upon the angle in which it was taken. Anyway, here we see an A dip, which is a normal variation. So some of the abnormal variations that we can expect to see in patients with a pulmonic valve would include 1. Pulmonary hypertension. In patients with pulmonary hypertension, there is absent A wave along with some midsystolic notching of the pulmonic valve, which produces what is called a flying W sign. And when you see this one, this is suggestive of pulmonary hypertension. Keep in mind, the absence of A wave and a flying W should be diagnostic for exam purposes of pulmonary hypertension. And here are a few different examples of pulmonary valve pathology that we can detect by M-mode echocardiography. Here's the normal valve, which shows the A dip, and then we have the valve opening. In patients with pulmonary hypertension, we already talked about the flying W sign. However, if you have a patient with pulmonic stenosis, please note there is a deep dip here and there's a notch in the early phase of the valve opening as opposed to the latter phase of the valve opening in pulmonary hypertension. So you need to keep these two diagrams in your brain, so you will be able to differentiate between pulmonary hypertension and pulmonic stenosis. Let's proceed. What does this M mode represent? What area are we recording, and what do you see? What pathology do you see? When you are ready, let us know. We will proceed. Okay, here we see a midsystolic closure of the aortic valve. A midsystolic closure of the aortic valve is indicative of an obstruction during midsystolic phase of the cardiac cycle. And generally we see this midsystolic closure in patients with dynamic hypertrophic cardiomyopathy with dynamic obstruction. That is, when the obstruction becomes prominent during midsystole, there is evidence of a midsystolic closure. So if you see this midsystolic closure of the aortic valve, you always need to think about dynamic obstruction of the left ventricular outflow tract. All right, here's an example. What do you see? Name all the structures that you see and let me know if you see any abnormality here. There are a lot of interesting physiological points that we can bring out in this particular tracing. All right, let's proceed. And here is a similar image. First, I want to point out there is a very good delineation of the septal borders, which is beautiful. And here we have the electrocardiogram, and here's the QRS complex, here's the QRS complex. Anyway, there's a beautiful septal motion posteriorly during systole, whereas the posterior wall is moving anteriorly during systole. Then during diastole, there is relaxation of the left ventricular walls. And here we have the right ventricle. We can measure the septal thickness during diastole. We can also measure the septal thickness during systole. Similarly, we can measure the septal posterior wall thickness during various phases of the cardiac cycle. I want to draw your attention to this little dip that we see here just before the systolic phase begins. Any idea what the dip represents? It represents the atrial activity. If you measure the amount of movement of this atrial activity in terms of diameter, you can actually calculate the atrial contribution in a patient during a cardiac cycle. Especially if you're dealing with a hypertensive, non-compliant ventricle, the atrial contribution could be quite significant. By hemodynamics, it has been shown that 40% of the cardiac output may be dependent on the atrial kick in patients with elevated end diastolic pressure. Anyway, we can see during systole they come together, and then there is relaxation of both these walls during ventricular diastole. By this image itself, we can do a lot of calculations and also find out left ventricular volume, stroke volume, plus left ventricular ejection fraction. That's what we use for decades before we moved on to two-dimensional echocardiogram and Simpson's method of tracing, volumetric measurements, three-dimensional measurements, and all these things. But still, if you get a good image like this from a 2D, extract an M mode, you can get a fairly reasonably accurate measurement of the left ventricular size, thickness, fractional shortening, and ejection fraction. And here is a summary of all the things that we can get from an M mode echocardiogram. Yeah, it is amazing. And here we have an interventricular septum during diastole, during systole, LV dimension during diastole and systole, posterior wall thickness during end diastole and during thickness. We can measure the fractional shortening here. So here are some of the normal values which you need to remember and memorize. Left ventricular end diastolic dimension, 37 to 56 millimeters of mercury. This is an important number, especially when we are dealing with patients with aortic regurgitation or mitral regurgitation. This number helps us to identify who is at risk of getting worse with time. Left ventricular end systolic dimension is 26 to 36 millimeters, and this is an index of how well the ventricle is able to contract, and is also an indirect reflection of the left ventricular fractional shortening and ejection fraction. The normal interventricular septal thickness should be less than 1.1 centimeter. The interventricular excursion should be between 25 to 70%, and the posterior wall thickness also should be less than 1.1 centimeter. The posterior wall excursion can be anywhere from 9 to 14 millimeters from this point to this point, and the thickness should go from 25 to 80% during ventricular systole. The fractional shortening of these walls should be 28 to 41%, and the normal ejection fraction is between 50 and 75%. A few more measurements with reference to the left ventricular M-mode. We can measure the stroke volume, which is between 75 and 100 cc. The cardiac output is generally 4 to 8 liters per meter, and the index is about 2.4 to 4.2 liters per minute per meter square. We can also calculate the LV mass. The LV mass should be like less than 300 grams in men and less than 200 grams in female. This is an important board question. The mitral valve E to F slope, it's not shown here, is between 50 and 150 millimeters per second. And I already mentioned this mitral valve E to septal separation should be less than 7 millimeters, or say less than 1 centimeter. Alright, let's continue. And we can measure the left ventricular ejection fraction by cubing the end diastolic dimension and end systolic dimension. By using this very simple formula, we can calculate the left ventricular ejection fraction. Similarly, we can calculate the left ventricular mass by using this complex formula. You can just pause the video and read it. So what do you see here, and what is your diagnosis? Okay, let's pay attention to what we are seeing here. First of all, the left atrium is dilated. Number 2, the aortic root movements are subdued. They are not swinging like a nice sine wave. So that means there is reduced cardiac output. Number 3, there is premature closure of the aortic valve. That means towards the end of systole, there's nothing really going through the aortic valve. As a result, the aortic valve prematurely closes. So this is also this patient has a conduction disturbance on the electrocardiogram, as you can see, which may also have some significance in terms of the advanced cardiac condition that we are dealing with. The normal opening should be like a box, but here it is almost like a pyramid. Anyway, this is representing reduced cardiac function, which we already deducted by looking at the aortic root movements, by looking at the aortic valve closure, and looking at the left atrial dimension. Let's proceed. What does this tracing show, and what is your diagnosis? Here's a normal normal M-mode echocardiogram. I want you to pay attention to the movement of the walls during systole. Here, the posterior wall is moving forward, the septum is moving backwards. So they are coming close together so that they can squeeze the blood into the aorta. But look at what's happening here. Here we have the posterior wall is moving forwards, and we have the septum also moving forward. So there is paradoxical septal motion. What is causing this paradoxical septal motion? Well, if you look at the electrocardiogram, the wide QRS complex should be a tip-off that you may be dealing with the left bundle branch block, which could be causing paradoxical septal motion. However, the paradoxical septal motion is not characteristic of just left bundle branch block. It simply means the paradoxical septal motion is an indication of the abnormal sequence of activation of the left ventricle itself. For example, in patients with left bundle branch block, first we have the activation of the right bundle, then there is abnormal activation of the left side, followed by activation of the septum, which is going to show some movements. So the abnormal septal motion may also be recognized by an abnormal perfusion on a nuclear SPECT image. Patients with the left bundle branch block, in addition to having this abnormal septal motion, which creates an inadequate cooptation of the mitral leaflets, can lead to early mitral regurgitation. We can see similar changes in patients following a PVC, coming from the left side particularly, and also in patients with pacemaker rhythm, because their ventricles are activated in an abnormal sequence similar to that of a left bundle branch block. Alright, let's proceed. And here is an example of a PVC which is showing the posterior wall is trying to move forward, whereas the septum is moving abnormally towards the front. So it depends upon the sequence of activation of the ventricular walls in patients with conduction disturbances or when there is an ectopic beat. What do we see here and what is your diagnosis? Pay attention to all the structures. As I said, it is important. Don't look at one obvious thing, because there are generally 2 to 3 things that are abnormal on any given tracing, and all of them put together will help you to make the composite diagnosis. So what do you see here and what is going on? First of all, let's look at this. And here I put a normal one just to give you an idea. Okay, normal one, we got a posterior wall, the septum, they are moving normally, which is good. And here we have the posterior wall which is moving normally, and then during the diastolic phase, there is some undulations. Instead of having a smooth motion here, we got some undulations here. So that's an important point to keep in mind. The next important point that you really need to keep in mind is look at the pericardium here. There's a thin pericardial space here, but look at the dense echoes, which is almost as thick as the posterior wall. So we are dealing with a patient with a thick pericardium, which means we are dealing with a patient with constrictive pericarditis. When we see a tracing like this with thick, dense echoes coming from the posterior region, always think about constrictive pericarditis, then look for all the findings that relate to constrictive pericarditis. So it's time for us to memorize all the findings associated with constrictive pericarditis. Here is a tracing with constrictive pericarditis showing thick posterior pericardium, and the tracing is a long one along with the inspiratory and expiratory cycles marked. So let's look at some of the clear-cut findings that relate to constrictive pericarditis. There is increased thickness of the pericardium, and if you see the increased thickness of the pericardium, you better put it in your mind, first diagnosis as constrictive pericarditis. Now then we have a paradoxical septal motion where the septum is, instead of moving, it is moving backwards and then coming forwards. So there's paradoxical septal motion at these early stages of the cardiac systole. Then the septal bounce during early diastole. If you look at the early diastolic phase, instead of relaxing, it has a bounce. There are multiple echoes. That is the early diastolic bounce they are talking about. And now look at the mid to late flat motion of the left ventricular posterior wall. And this is an important, if you look at here, it's like a straight line here, the left ventricular wall motion. That means it is a standstill during the mid to late diastolic phase. Again, there's a rapid early diastolic E to F slope, which we don't have this on this tracing. And there is also a premature opening of the pulmonic valve. And of course, in patients with pericardial tamponade or restrictive cardiomyopathy or constrictive pericarditis, they all have dilated IVC. And in patients with constrictive pericarditis, the respiratory variations are pretty blunted, and so are the same findings in patients with the tamponade. Okay, let's proceed. This got to be a spot diagnosis. You don't get too much time. No. Okay, mitral valve prolapse. Mitral valve prolapse, you can see a mid to late systolic prolapse of both the anterior and the posterior leaflets. Sometimes the prolapse can involve only the anterior mitral leaflet. There can also be sometimes the pan-systolic prolapse of the mitral valve. Along with that, we may see some redundant echoes suggestive of the loose redundant mitral leaflets that are seen in patients with the mitral valve prolapse. Whenever we see mitral valve prolapse, you also have to remember it may be associated with some other congenital abnormalities such as Marfan's syndrome or a patient with atrial septal defect. Again, patients with the mitral valve prolapse, if they have a murmur, may be prone for endocarditis. So all these things need to come through our mind when we look at a tracing, be it M mode or two-dimensional. All right, what do you see here and what is your impression? This is a tracing at the level of the left ventricular cavity. Well, no doubt we see some pericardial space here, but maybe not enough to call a big pericardial effusion. The wall motions are exaggerated. So it is like a patient with a hyperdynamic heart, where the ventricle squeezes quite vigorously, and they may have an ejection fraction of 75% or greater. We see this especially in elderly hypertensive women who have small left ventricular cavities, like their end diastolic volume is like 50, end systolic volume is like 15 ml, and they have just small cavity and the ventricle just squeezes almost with each cardiac cycle. Of course, we have normal wall motion here, and also there may be some evidence of left ventricular hypertrophy we see in these patients. Obviously, these patients have a small stroke volume, even though they have a pretty high left ventricular ejection fractions. All right, let's continue. What are we seeing here, and what is your diagnosis? Okay, here's an example of, first of all, we need to identify the various structures so that we know what we're dealing with. Here we have the interventricular septum. This is part of the mitral valve tracing. Here we have the infralateral wall of the left ventricle. There's a reasonable pericardial effusion here, which may be small. But anteriorly, we also have some small pericardial effusion. The most important finding in this is it's a moderate echo-free space anteriorly, which suggests moderate pericardial effusion. The most obvious thing is the diastolic collapse of the left ventricular wall. This represents moderate pericardial effusion with evidence of a right ventricular collapse. But we don't need to have a large amount of fluid to have cardiac tamponade. In an acute situation where there is bleeding, you can have 100 to 150 ml that can cause cardiac tamponade. Okay, take a look at this one, and what do you think? Well, there are some things already put here, but that's all right. Here, we have a dilated left ventricle. The septal motions are variable because of a irregular rhythm with PVCs. Anyway, the septal excursion is reduced. the posterior wall excursion is reduced. The left ventricular cavity size is greatly increased. So we are dealing with the dilated left ventricle, decreased wall motions, septal dyskinesis. As you can see, when this is moving forwards, this is moving forwards also. And there's a wide QRS complex, as we can see here. And of course, we can say this patient has reduced left ventricular ejection fraction. And of course, when they actually measured, they came up with an ejection fraction of 12.5%. Frequently, we see these kind of patients in our practice, and it's good to do some M-mode echocardiograms because you will be able to identify some wall motion abnormalities much better than we can with other modalities. Okay, what is your diagnosis? You got 10 seconds or maybe 30 seconds. In order to diagnose what is happening in this particular tracing, we need to know how the normal structures look. Once you know how the normal structures look, it should be a spot diagnosis. Let me prove it to you. Here's how a normal mitral valve opening is during a cardiac cycle. And look at the mitral valve here. First of all, the posterior leaflet is moving anteriorly during the cycle, during mitral valve opening, diastole. Number two, there is increased thickness of the mitral leaflets, both the anterior and the posterior leaflets. There is a significant decrease in E to F slope. You hardly see any atrial wave whatsoever. So we are dealing with a patient with mitral stenosis. The most common cause is rheumatic pathology. So you're dealing with the mitral valvular pathology when the E to F slope is reduced, when there are increased echoes within the envelope, when the posterior leaflet is moving anteriorly, you're dealing with mitral valve stenosis. Occasionally, you see something popping in and out of the mitral valve during diastole. And when you see something like this, you need to be concerned about a mass. The mass could be a left atrial myxoma, or it could be some vegetation floating in and out of the mitral valve orifice. The vegetations are generally small, they are isolated and they are localized, whereas a big left atrial mass can occupy the entire mitral valve opening. And another important point would be that we could see changes from beat to beat. Anyway, what do we see here? Here we have a tracing which has a new abnormal finding. Alright, here we are seeing like undulations of, coarse undulations of the mitral leaflet during diastole. But it is not during early diastole where we can see some undulations of the mitral leaflets. Whenever you see coarse undulations of the mitral leaflet, and especially if the ventricle is slightly enlarged, the aortic root is enlarged, then you need to think about some of the differential diagnoses such as aortic regurgitation. Aortic regurgitation can cause diastolic fluttering of the anterior mitral leaflet because that's the one that is closest to the regurgitant jet. And then we can also see diastolic fluttering of the aortic valve leaflets themselves. There could be premature closure of the mitral valve because of the increased end diastolic pressure from this regurgitant volume coming into the left ventricle right after the systole. And there may be some premature opening of the aortic valve. For the same reason, when the left ventricular pressure goes up, the aortic valves may open prematurely. Along with that, we may see some left ventricular dilatation in patients with advanced aortic regurgitation. What do you see here? Well, we see some shaggy echoes within the mitral valve. They are not like covering the whole envelope of the mitral apparatus, as I talked to you about before. And when you see these patchy opacities in the mitral orifice area, then you always think about mitral valve endocarditis. And here's another example of actually a left atrial myxoma. And one of the characteristic features of this left atrial myxoma is you see them popping in and out of the mitral valve. And when you see that, generally there is a space between the mitral leaflet opening and the appearance of the echoes produced by the left atrial myxoma itself. So this is an example of a left atrial myxoma. Here's a two-dimensional echocardiogram showing the left atrial myxoma sort of going in and out of the mitral orifice. Okay, what do you see here and what is your diagnosis? Okay, let's pay attention to some of the things that are visible here. Here's the aortic valve, and below that there appears to be what could be a membrane. So we are dealing with a subaortic membrane which can cause fluttering of the aortic leaflets along with the midsystolic closure and even premature closure of the aortic valve. So whenever you see something like this, you should keep in mind you may be dealing with the subaortic membrane or hypertrophic cardiomyopathy with dynamic left ventricular outflow tract obstruction. What are we seeing here? What is your diagnosis? Dilated cardiomyopathy. You should be able to move pretty fast now. Dilated cardiomyopathy, increase in left ventricular end-diastolic volume, reduced septal and posterior wall motion, reduced ejection fraction, reduced left ventricular ejection fraction. And as you can see in the 2D echo, the left ventricle is grossly dilated in all directions. Okay, what do we see in this tracing and what is your diagnosis? Sometimes these tracings can be unfriendly, but we have to start with the structure that we can identify best and then try to reconstruct the remaining parts of the images. Okay, let me give you some help here. Here is a similar tracing, and as you can see, we start off with the posterior wall, which we can see very well. That's point number 1. Point number 2, there is some echo-free space posteriorly, so that means there is pericardial effusion. If this is more than 1 centimeter, we are dealing with moderate pericardial effusion. We also see echocardial space anteriorly, so there is evidence that we are dealing with some moderate pericardial effusion. Along with the moderate pericardial effusion, we also see there is a large echo-free space behind the pericardial effusion. So this represents a large pleural effusion in addition to the pericardial effusion. And along with that pericardial effusion, we also have exaggerated movement of the right ventricular wall. Especially, we also have an exaggerated motion of the right ventricular wall. When we have a moderate effusion and when we have exaggerated motion of the right ventricular wall, we need to be concerned about pericardial tamponade. In order to really pinpoint the diagnosis of pericardial tamponade, we need a better mitral valve echo along with respiratory cycles marked, so we can see the mitral valve movements during the various phases of the cardiac cycle. And here is an example of what we call a swinging heart, which is characteristic of a patient with a tamponade, but not always. But as we can see, the ventricle's dimensions are changing and the right ventricle collapses during certain part of the cycle. During inspiration, there is increase in right ventricular cavity size. During expiration, there is almost a collapse of the right ventricular cavity. And you also can see a large pericardial effusion right behind the posterior wall of the ventricle. Here we have summarized some of the findings that are most relevant that we need to know and memorize when it comes to tamponade. The compression of the has to be less than 7 millimeters. The increase in RV size and decrease in LV size with inspiration. As we can see during inspiration, Here's during expiration, the LV size is big, but it is small here. So there's an increase in RV size and a decrease in LV size during inspiration. We covered that one. The mitral valve E to S slope is decreased, which we don't see here. Same thing with this one. This RV diastolic collapse, which is quite sensitive. We do see RV collapse here, but because this is taken at a very slow sweep, we can't tell between systolic and diastolic. But nonetheless, here we can see there is RV diastolic collapse. Obviously, these patients will have dilated inferior vena cava with minimal changes during respirations. This is an example of measuring TAPSE, T-A-P-S-E, tricuspid annular plane systolic excursion. As you know, when the ventricles contract, they contract from the base to the apex. For the longest time, I thought the ventricles squeezed from the apex to the base. But if you actually watch it in slow motion, the bases move towards the apex, and as the bases move towards the apex and when the apex squeezes, the blood is projected into the main arteries. We can use this technique to see how well these ventricles are able to squeeze and reduce their volume during systole. On the right side, it is measured by seeing how well this tricuspid annulus moves during right ventricular systole, which is an indirect reflection of the right ventricular function. The more vigorous the movement, the better is the left ventricular function. The less the tricuspid valve movement, tricuspid annulus movement, it represents reduced right ventricular function, especially when it's combined with increase in right ventricular dimension. As I said, you should always look for more than one parameter. It's better if we have 2 to 3 parameters to confirm your diagnosis. A dilated right ventricle, elevated pulmonary pressure, reduced tricuspid annular plane systolic excursion. When you put all these things together, you can say, yeah, we are dealing with a patient with right ventricular dilatation, pulmonary hypertension, and reduced systolic function. That makes sense, especially if you're dealing with a patient with either left heart failure or a patient with a chronic lung disease or a sleep apnea who has unexplained right ventricular dilatation. Then it makes sense to find out if in fact the right ventricle is functioning normally or not. Anyway, looking at the tricuspid annular plane systolic excursion, the normal is supposed to be between 15 to 20 millimeters. It is supposed to be mildly abnormal if it is between 12 to 15 millimeters. It is moderately abnormal if the excursion is 10 to 12 millimeters, and if the excursion is less than 10 millimeters, you are dealing with a sick right ventricle. Houston, we got problem. Here's an example of how electrical conduction abnormalities can reflect on the M-mode echocardiogram. Here's a patient with a WPW, noticeably has a pre-excitation with a pre-activation of the posterior wall, and you don't see the same activation of the septum. That may suggest the origin of the accessory impulse. I thought that was quite interesting. Sometimes we see early closure of the mitral valve. Under what conditions do we see early closure of the mitral valve and why? The most common cause of early closure of the mitral valve is aortic regurgitation. Because of the aortic regurgitation, there is a blood returning from the aorta into the left ventricular cavity, and as the pressure builds up, the mitral valve may close prematurely. That's what's called early mitral valve closure or premature mitral valve closure, because of the increased end diastolic pressure in the left ventricular cavity, and when this exceeds the left atrial pressure, obviously the mitral valves close. Along with that, if it's from aortic regurgitation, you may be able to see some fluttering of the mitral leaflets, especially in the anterior leaflet. This can also be seen in patients with various types of heart blocks, and maybe also in patients with flutter, when the atrial activity does not really coincide with the other activities during a cardiac cycle. So just to conclude, what does M-mode offer beyond two-dimensional and three-dimensional echocardiography? Well, let me put it simply that it provides better estimation of time intervals. It provides better estimation of the wall motion and abnormal motions. We can measure pressure half time in the absence of tricuspid or pulmonic regurgitation. It gives us a better understanding of paradoxical pulse and findings in patients with tamponade. We may also be able to diagnose certain cardiac arrhythmias better than we can with EKG using an M-mode echocardiogram. Color M-mode may be useful for timing and flow propagation in patients with valvular regurgitation. I hope this presentation will help you to have a better grip on M-mode tracings for your echo board. Thank you so much for watching, and please do check out my books on Amazon.com. We have a lot more educational videos on our YouTube channel. Please take a moment to browse through them. If you want us to create any other educational videos, please drop us a message. We'll be happy to create those videos for you. We also have hundreds of educational videos on our YouTube channel, and please do check them out and stay tuned for next presentation. I am Dr. NIK NIKAM, and thank you so much for your time.